like off the screen, including the thank you for Barbara Turnbull for the money that she provided, among others. Some of them are on the screen, the CIHR obviously is off the screen as well. What I'm going to talk about is how we can strengthen what residual connections may remain after the spinal cord injury. Most spinal cord injuries are incomplete. This is work done with a number of people. And just by way of background, I'm going to talk about a condition known as foot drop, which is quite common not only after spinal cord injury, but stroke, multiple sclerosis, and a number of other conditions. And there are foot drop stimulators, including one that we developed called the walk aid. It can correct many of the problems. And but what we found is in addition to picking up the foot, that the stimulators also have a very potent effect in strengthening residual corticospinal connections. So to try and document what happens as a result of the chronic electrical stimulation that people use, we followed 73 people who were new users of the walk aid over a period of up to a year or more. They had a variety of conditions, and I divided them into two. One that were stable, that is people with spinal cord injury, stroke, and a few other conditions. And those that were progressive, mainly multiple sclerosis, although there were, again, other conditions. And these were people that had the injury chronically, so they had the injury at least for 6 years, 6 months on average, 11 years. So you wouldn't expect anything to be changing except for the fact that we introduced this new treatment modality. And this is a little bit of a complicated slide, but if I take you through it, I think you'll understand. So this is a period of 12 months that we studied. On day one, when they used the stimulator, you can see that the response to the walking speed increased. So this is without the device, this is for a stable population with the device. But you can see as a result of using it, the increase got bigger and bigger. Over a period of a year, the walking speed with the device increased by 43%. So that's quite a dramatic change in people that have been stable for many years. But the interesting thing is at each point we turned off the stimulator, and you can see that they still walk a lot faster, about 32%. So something is changing in the nervous system as a result of using this stimulator on a daily basis. The results weren't quite as good for the people that had multiple sclerosis. They began to improve, but then they declined as a result of the fact that the disease is a progressive disorder. But even a year later, they were still doing better with the device than they had been initially at the normalized value of 1 without the device. So what's happening? Well, we could do a variety of tests. We could just ask people to contract the muscles voluntarily and look at the maximum voluntary contraction. And the purple, again, is the stable group. And you can see that their ability to contract the muscle is improved by nearly 50% as a result of using the walk aid stimulator over a period of years. If we stimulated magnetically over the motor cortex and recorded the responses, they also increased by about 50%. And the walking speed in the population increased a similar amount. But the results weren't quite as good with the people with multiple sclerosis, but there still were significant changes. So the question is, use of electrical stimulation on a daily basis does strengthen whatever connections are residual and remain after the spinal cord injury, but is it the best way to strengthen the residual connections? Traditional physical therapy would have people doing exercises. They may use some electrical stimulation, although on a less intensive basis, because it would just be when they visit the clinic rather than on a daily basis for 8, 10, 12 hours a day. And I mentioned transcranial magnetic stimulation, using magnetic stimulation over the brain. This has been suggested as a therapy as well as for measuring the motor evoked potentials. And so you could use all these with electrical stimulation. You can also have electrical stimulation just before the magnetic stimulation, so that when the sensory volley gets to the brain, it is added to the stimulation that you're applying. This is something called paired associative stimulation. It's kind of like Pavlovian conditioning. So it ends up with about 8 different protocols that we follow. We look at voluntary exercise alone, functional electrical stimulation alone, combining functional electrical stimulation with exercise, transcranial magnetic stimulation. We can add exercise to that. We add electrical stimulation to that. We get the paired associative stimulation that I talked about, again with exercise. And you can also get additional facilitation by using 2 pulses of the transcranial magnetic stimulation. So we added on this additional doublet EMS, again with exercise. So, which is best? We looked again, now we looked at control subjects who were age matched to the people with the progressive disorders, that's the multiple sclerosis, and the stable disorder, that's spinal cord injury and stroke. And the clinical groups were also fairly well matched in terms of the duration. Again, these are very chronic patients. So this just shows a couple of parameters of what they had initially. This is the max involuntary contraction of control subjects. You can see that these were severely affected by the injuries. They were not different from one another, but very different from the control group. You did the magnetic stimulation. Again, you can see that even greater effect on the corticospinal pathway than these individuals. Peripheral nerve wasn't nearly as much affected. The spinal reflexes a little higher in the spinal cord and stroke group. Probably there was a measure of spasticity, but again, not dramatically changed. So, which of the 8 is the best? This is obviously too much data. This is just to show that we did lots of work, we recorded lots of patients, got lots of numbers. But the disappointing thing is that nothing really sticks out. This is maybe a little higher than some of the others. That's the TMS doublet plus voluntary control. Rather than take you through all these curves, I'll just summarize the results that we got. First of all, the ones that seem to combine several modalities seem to produce the larger increases, and they were statistically significant. So this is the paired associative stimulation at rest or with voluntary control, the doublet transcranial magnetic stimulation. We measured the changes both at rest and with voluntary contraction. The resting changes in the resting motor evoked potential were larger but more variable. And I should mention, though, that a lot of these people were severely enough affected that they didn't have a rest MEP. But so there's quite a lot of variability in this group, and only the doublet TMS was significant. So clearly there were some changes occurring at the cortex, less, perhaps some at the spinal level, but not at the neuromuscular level. If we grouped the 8 different protocols to see whether there were differences between the groups, the green is the people with the control subjects. You can see over a period of an hour they had 3 10-minute sessions of whatever protocol they were receiving, and then we followed them for another 30 minutes. You can see see that there's a clear improvement in the control subjects, less in the people with stable conditions, and almost nothing much in the people with progressive disorders. So at least the one-time therapy is not as effective, perhaps because of the central fatigue that's common in multiple sclerosis. But one sort of take-home message that we found is that the number of methods that you use to facilitate, the more methods that you use to facilitate, the better the response. So if we use one type of action, there was only a small change, two types of action, there were bigger changes, three types of action, and we're now significantly higher than with a single action. So in conclusion, the people with the progressive disorders, multiple sclerosis, did not respond significantly to any of the protocols for reasons that are still not clear, but probably are related to this phenomenon of central fatigue that I can talk about a little more if people are interested. Those with stable disorders were intermediate, and there's no clear winner. There's no magic bullet. But what appears to be the case is the more types of stimulation you apply, the better you are at strengthening any residual connections. And the somewhat weaker effects in the clinical group may result from them just having less tissue to facilitate. Thank you.